Доброго дня, шановні.
Good afternoon, dear participants of this briefing, dear visitors. USMC starts its working day, and our first briefing is devoted to the developing of efficient network of healthcare institutions at the local level in conditions of decentralization. And our first moderator and speaker is Mr. Evgeny Prylypko, director of the project of efficient management of healthcare institutions in decentralization. Dear visitors, our project is being assisted by the You Lead with Europe project. The poor health care and in decentralization is a great risk for local communities. This means that we should orient our services to local people in delivery of efficient services. At the same time, we clearly see that there are a lot of contradictions in current situation. The healthcare reform requires decentralization on one hand. On the other hand, it requires cheaper services to be delivered to the local service level and decentralization. That this requires concentration of resources in a small hospital and with a big flow of patients, and this means that hospitals are located in the regional or district centers. The state has to provide proper infrastructure. That is, now we are at the stage of hospital districts formation. We are creating cluster hospitals, general hospitals, and other types of hospitals are needed for this stage. We all understand that this brings social and economic risks to the hospitals located in the cities under 40,000 of population. Sometimes managers of small hospitals do not properly understand what the objectives are, what the tasks are. They do not understand the flows of finance and the flows of the service delivery, which means that sometimes they feel that they are shocked and do not know what to work. In the regions, this results in unwise management decisions, non-delivery of services, and actually this results in non-delivery of critically important healthcare services. The hospitals in the centers, which cover up to 10,000 people, amount to 35% of the general service delivery numbers, and this means that there's a considerable amount of hospitals which are not included into the hospital district network. And more and more we hear concerns from the local communities about general structure and organization of service delivery. And we are trying to provide organizational and political solutions. Here, I mean the healthcare policy solutions, bilateral contracts. We will change the patient routes. We'll decide how to offer services of specialists. The hospitals which will be included in the system will be provided with the funding from the state budget for the construction of premises and for medical equipment. And this provision of resources will be based at the well substantiated request from the hospitals and outpatient clinics. That's our joint. By the way, I would like to thank you to Oleksii Iaremenko for his interview. But the last question in that interview was about the destiny of those local communities which are under 20,000 of people and how hospital services will be delivered to them. Thus, our project together with You Lead Europe was aimed at formation of an integral network of healthcare institutions which will provide optimal solutions for the patients, for the healthcare institutions, for budgeting institutions, etc. And with this, I'm happy to give the floor to Mr. Soren Herbst.
Floor to Soren Herbst, the head of multi-level governance unit of program You Lead with Europe. Soren, the floor is yours.
Дякую, Yevhen. Good morning, доброго ранку, dear friends. I hope you can hear me. The program You Lead with Europe has always been a trustworthy and consistent partner for Ukrainian municipalities in their efforts to develop a sustainable and effective network of healthcare institutions. From the very inception of the medical reform in 2017, the program provided our partners, you, with expert support and learning materials on every aspect of the healthcare transformation in Ukraine. The direction and the logic of the reform, the new scope of rights and responsibilities of local self-governments in the healthcare sector, the details of the new financing mechanism via the National Health Service of Ukraine. Together with our team of experts, You Lead with Europe has always been a reliable source of expertise and competence on how to develop and manage sustainable networks of healthcare institutions in municipalities throughout the whole period of medical transformation in Ukraine. Currently, when the whole of Ukraine is facing now an unprecedented challenge of the Russian military aggression, You Lead with Europe continues to provide vital support for our partners in municipalities throughout Ukraine with all available means, because we believe in the strength of Ukrainian Hromadas and in the strength of local self-government. Just recently, we procured and delivered to 333 Ukrainian municipalities kits of emergency equipment in the sectors of repair, lighting and shelter for the total value of 15 million euros. And we brought all this to Ukraine in only 3 months. Those kits were specially designed to ensure maintenance of livelihood in municipalities that had to deal with infrastructure collapse or the influx of internally displaced people caused by the Russian military aggression. And it goes without saying that You Lead continued to conduct its regularly online sessions on consultations for representatives of local self-governments on the whole range of topics related to the healthcare networks in Ukrainian Hromadas during the martial law. And today we are here to present the outcomes of one of our most innovative projects in the healthcare sector, effective governance of the healthcare facilities network in a decentralized environment, which has been implemented together with our partners from public association Healthcare Transformation Forum. Launched in October 2021, this project aimed at increasing the efficiency and ensuring sustainability of healthcare systems at the municipal level through better governance and responsible decision-making. And I'm very pleased to say that despite the immense disruptions to the project implementation due to the Russian aggression, the project was nevertheless successfully completed thanks to the unwavering commitment of our partners from Healthcare Transformation Forum, and also a steadfast support of You Lead with Europe. We sincerely believe that the implementation of this project has greatly contributed towards shaping an efficient and sustainable Ukraine healthcare system for future periods. And I would like to assure you the unwavering and continuing support of You Lead with Europe on your way to complete victory. Thank you very much. Дякую.
Thank you very much. Thank you, Mr. Soren, for your support for the project, cooperation, faith, and good wishes for us. And of course, we have quite a lot of important work ahead to ensure accessibility and availability of healthcare at municipal level and renovation of healthcare facilities. And we sure hope for further development of cooperation with You Lead with Europe. Thank you very much, Mr. Soren.
Дякую. Thank you.
Отже, колеги, ми продовжуємо.
Dear colleagues, we continue. The project and experts and local communities face the tasks to respond to the very important issues. I won't repeat those issues, but looking for the proper responses, we found that proper solutions depend on very important changes and regulatory procedures which are to be introduced at the center level. With this, I have pleasure to invite Mr. Oleksii Iaremenko, Deputy Minister of Healthcare in European integration. I would like to thank the project about developing efficient network of healthcare institutions at the local level in decentralization and under martial law. And the project was launched before the war, and by the year 2022 we had great plans in reform of the local healthcare system formation. Unfortunately, the war introduced changes to this project, and today we have to respond to the tasks of post-war restoration of healthcare institutions, and the government works much on the reconstruction plan, including the healthcare institutions. We understand that this will require mobilization of internal and external resources to make a big leap in the healthcare system development. At the same time, we do not wish to postpone our reformation plans. The law was passed number 2347, which introduced changes to the legislative base and described the future changes about creation of capable network, information of proper network network of healthcare institutions. Actually, with this law, we were targeting two objections: quality of treatment and accessibility of healthcare services, including the payment, including the free services. Also, that included the proper connections, that is, capability to reach the point where the service is delivered, to be transported there, etc. Recently, the decision about hospital districts was made. The role of those hospital districts was determined. The cluster clinics and hospitals were clearly explained, and cluster institutions have to cover minimum 150,000 people, the district with such population, and they should have proper access, allowing people to get there easily. Also, we change the ownership of these healthcare institutions and the management of the healthcare institution. This means that local communities become owners of hospitals and outpatient clinics, and this means that the community which has such a cluster hospital or outpatient clinic in its territory, they are responsible for the whole population of neighboring towns and villages which are included into the cluster territory. Similarly, general hospitals are to provide services between 2 and 6 communities from 50 to 100,000 people. This brings us to the need to amalgamate several hospitals and implement fully the law about cooperation between local communities. Only a joint effort of local communities, which will allow to unite resources, will allow these local healthcare institutions to provide proper service, that is, proper quality of treatment and proper accessibility. Today, I would like to point out that the central focal point of all these measures is the patient, is a patient. That is, we have to keep in mind the accessibility of services and the affordability of services, so to say, and the quality of services. To provide all that, we have to strengthen managerial potential. And in strengthening managerial potential, we appreciate very much the assistance provided from this project. And I encourage local hospitals to study the recommendations provided by the project, how to strengthen managerial component to improve the quality of healthcare services. The next aspect to review is the role of a hospital or outpatient clinic in a network. In the past, we used to have village, town, city hospitals or outpatient clinics. Now, with the cluster hospitals, we will be able to form the patient routes more clearly. For example, the pilot projects in treatment of heart strokes and insults will be reformed and clearly explained to the patients and made very straightforward. Our objective is to unite the healthcare services in one network. For such institutions, nothing will change in 2023. At the same time, there is a group of services which are insufficiently developed in the current healthcare system. For example, the nurse care, the one-day surgery, palliative services, etc. Those blocks of services could be offered in the hospitals, which will be brought closer to the patients. During next year, we will develop the methodology and support materials how to introduce these new services into everyday practice of our hospitals. And we believe that each type of hospital will have its own role. We have no intention to close for good any hospitals. Instead of that, we will strengthen the special direction in each of them and to procure new equipment for them. I would like to thank to the project and to the teams which worked for it. Oleksii, thank you. We'll hope for the cooperation and for the scaling up of your experience and scaling up of the outcomes of the project, because I believe that still many people require broader explanation about new services, about new system, about new approaches, and that's why I hope that our cooperation will continue during the year to come, and that we'll be able to provide even individual models to the hospitals which cover less than 40,000 of population. The majority of them, which offer services to 10,000, 20,000 of people, they require individual solutions, and it is difficult to standardize them. Because everything here locally depends on the situation in the local community. Thank you, Oleksii. And now we continue our press conference. I'm pleased to give the floor to Ms. Kateryna Fishchuk, representative of the WHO office in Ukraine. And even before the beginning of the project, the WHO office in Ukraine was involved into the healthcare services decentralization reform in Ukraine. And currently we invited the WHO representative to add a couple of words on the expectations from the project. Thank you, Evgen. Today, we follow up the project development and the impact which it makes in Ukraine. And today, I would like to share with you the document which was recently developed by WHO in summer this year, which offers the right set of principles for the post-war reconstruction in Ukraine. We understand that as of now, the healthcare reform will need to continue simultaneously with the healthcare reconstruction in Ukraine after the war. I will provide the link to it. The main objective of this document was to introduce healthcare reform and reconstruction as a part of overall reconstruction of post-war reform. So in general, the objective is not just to restore, but also reform the healthcare with the involvement of both domestic and international investments, and to build up a network which we would like to see in Ukraine. We paid special attention to the priority setting and the sequence of steps. So the principles: financial protection, the patient to be centered on a patient, accountability, resistance proof. The set of principles was guided by the general understanding that the main objective for healthcare management is how to provide proper services to individual patients and to healthcare system in general. Those principles which I mentioned, they are related, they match the challenges that are faced by Ukraine today. This is Euro integration and post-war reconstruction. And to some extent, these are the same problems for each healthcare institutions in Ukraine. When you look at the principle, they may look rather abstract, but actually they will bring rather specific outputs and even outcomes. I would like to describe some principles. For example, if we discuss individual services for population and the need to provide quality services to people, and of course, we should focus our attention at the strengthening of first aid, primary aid delivery. This means strengthening multidisciplinary approach, integration of additional services which are either not provided or are very in a very limited amount, like psychological health. Part of rehabilitation services, the need in which is growing. Active introduction of multiple forms of multiple organizational forms, strengthen cooperation between healthcare institutions for better service delivery, and without digital infrastructure, all that would not become possible. Another example, when we discuss the investments into physical infrastructure, we all are keen to provide services, but the physical infrastructure is a precondition for that services. And here we will need to rebuild and to extend the network of services, so the multi-profile institutions will become the priority, unlike the single profile institutions. In a big country as Ukraine, this process have to cover all the level, the top level of service delivery and the lower level of service delivery. We have to plan for the whole network, which was mentioned by Oleksii Iaremenko. The local community has to come to consensus how the network should look like before it apply for investments and start investing into it. At the projecting stage, it is very important to understand what you want to get eventually. Following the 5 principles which I mentioned, is recommendation number 1. The second recommendation is what to not to do when we keep in mind the 5 principles which I mentioned. Then infrastructure of healthcare institutions should not be based on the ownership and property. It should be based on the territorial approach and the amounts of population. There should be comprehensive investment into a system, but not following the treatment of some diseases, etc. And when we discuss general funding of healthcare system, we believe that we should not step back from the pay-as-you-go funding system. And which means procurement of services through the National Healthcare Agency. If you look at the patient centrality, staff provision, funding, we have good examples of the best practices, and in our report we provided links to such best practices. When we look at the sequence and priority setting, we also have some considerations about that. And especially keeping in mind reconstruction, we think about the primary level, primary services, and all the humanitarian aid which comes to the country should be integrated to this primary service delivery level. And we are thinking about better access to these services and about additional services, public healthcare, psychiatric healthcare, etc. And service delivery at the local level, communal level, is of primarily importance for the users. And also we mentioned the need for reconstruction of multi-profile, multifaceted institutions, and more specialized institutions should be based around such institutions, and in a long-term perspective, this will decrease financial resources to be spent on better delivery. And a major part of the budget for healthcare would not be wasted on utility services, maintenance of multiple buildings and premises, etc. The majority of healthcare budget should be spent on service delivery. This is our overall objective. Thank you, Kateryna. I'm familiar with the document which which you mentioned, and today we are demonstrating the results of our project, and it coincides with what you mentioned. And of course, the project has gone beyond the original framework, and we had analyzed the primary healthcare service delivery. We touched the bringing closer of primary services and the need to open outpatient centers and formation of hospital network even before post-war reconstruction, which you mentioned. I believe that this coincides with our approach. We all understand that we have to start to act today. Today, we're dealing not with a simple reconstruction, but with renovation, which means change of approach, introduction of new medical technologies, etc. Actually, everything that you had shown on your slides is reflected in the outputs of our project, which slightly go beyond our mandate, but actually that was involved into what we wanted to achieve. Dear colleagues, let us continue. Now, I would like to give the floor to representatives of our stakeholders and beneficiaries of our project, representative of the owners of healthcare institution, that is local communities. Valentyna Poltavets, our expert community recently had signed a memorandum on cooperation about improving healthcare services at the level of local communities, and this makes grounds for our further cooperation, and which will allow us to resolve a lot of issues and involve to the outputs of our project many local communities. Valentyna Poltavets, the floor is yours. Dear friend, thank you for your attention to the local communities, local communities in small towns, in rural areas, and I should say that the focus of your project was on that small communities, and we appreciate very much your work, which had shown the situation with these hospitals and outpatient clinics. I would like to focus on several aspects. We are an association of small local communities, and from the very beginning of a healthcare reform, we had an understanding that the second level medicine should not be within the responsibilities of local authorities. But nevertheless, with the amalgamation of districts, administrative districts, we face the question, what should be done with what to do with the hospitals, etc. And eventually we found ourselves authorized to care about the second level second level of healthcare services, which means that almost 300 hospitals and outpatient clinics have not received the definition of their role in the reformed system. There are district hospitals, there are big cluster hospitals, but what to do with these more than 320 hospitals? What would be their role in the system? We need a roadmap for the development of these healthcare institutions. We are not thinking about maintaining infrastructure. If we take the education reform and recollect the old Soviet approach when no schools were allowed to be closed in the villages. So in education area, we have analyzed the needs, we have analyzed the capacities, and managed to build up a good educational system, a good network of schools, and we even have closed schools in some communities. The same approach should be taken in the healthcare sector. But before doing that, we have to decide how the healthcare institution has to function. When you look just at the number of inhabitants in the area, 20,000, 30,000, 40,000, it says actually nothing about access to the healthcare services. For example, in Chernihiv region, where there are a lot of forests, where the accessibility is hampered with the scarce network of roads, the situation, when you keep in mind just number of inhabitants, is not proper. The same is true about the mountain regions, in Carpathian Mountains, where the accessibility is also difficult. We need to understand where the district hospitals find themselves now. That is the reason why I stand for transparency, for openness, and when we characterize any community as capable or incapable, whether we characterize educational community as capable or incapable, I think that's not fair. The state, the central government has to offer proper healthcare services to the local residents, and the level of the healthcare institutions should be raised. The functional level of those institutions should be raised. Okay, if any healthcare institution is called as incapable and the management there is not good, okay, what would this mean for the local residents? That they will be deprived from the healthcare services or not? Then about the administrative service delivery. In some places, we do not have the such administrative service delivery, administrative services centers. Unfortunately, the Soviet system, which was based on the district hospitals, and the district hospitals are very low, at a very low level. We call them incapable, but and the accessibility of such hospitals was very low. The roads were bad. No bus routes to such hospitals were not created. But as of now, we do not have any public transport allowing access to such hospitals. If now do not create proper routes to the cluster hospitals, our residents in rural areas would not get timely healthcare services, while our mortality is a rather high level anyway. So we have to start dialogue and to simulate the better ways how to use the existing hospitals and how to allow them to deliver proper services, because it is very easy to close something for good, but this won't resolve the problem of service delivery to local residents. We are very grateful to Evgeny, and let us plan together and have a dialogue with the project experts and assist our local communities in making those hospitals efficient in service delivery. Thank you for this intervention. Despite all the risks which we sound up and which we study carefully, I'm very optimistic. It seems to me that we have been starting the dialogue on time. It could be started earlier, but it is not too late now. And what I've heard from Oleksii Iaremenko also sounds optimistic. Of course, the risks are high, and we have to invite international domestic experts, although these risks, they exist everywhere, not just in Ukraine. We have to simulate properly and to create very good models. All the communities, they are different. And we know quite well that the needs of local communities from Transcaucasia, for example, they are they in very tough situation. For example, the local community is incapable, and the local hospital is incapable. The level of healthcare risk is high. For example, the timber processing enterprises are located there, and the access to cluster hospital is hampered because of the removal remote mountain roads, and this all demonstrates very special needs of local communities. The territorial communities and owners of healthcare institutions should understand the level of complexity of the tasks and the level of responsibility for local population. And even in cases when local community does not own its own clinic or center, it nevertheless have the responsibility for healthcare service delivery in the local community. So they have to maintain cooperation with the neighboring community which owns the healthcare institutions. Now I come closer to the description of our project. I'm not going to present everything and all our outputs. The full scale of our outputs, the full amount of our outputs will be presented at the special press conference on September 29. As of now, I will present just the main outputs which influenced strategic development and transformation of healthcare system in general. 5 local communities participate with their healthcare institutions, both from primary and secondary level, participated in our project. Out of them, only one was considered to be a general hospital. All other hospitals were the cluster hospitals. We also had a reference hospital from Transcarpathia, but they do not have a center of primarily sanitary assistance. They had only ambulance center, and this used to be a very interesting case. The period for project implementation coincided with the beginning of full-scale aggression, and we had to reschedule our cooperation with local communities. Vasilevska local community is under occupation. It is in Zaporizhia region, and we still hope that we will have a possibility to continue our cooperation with that local community in future. In this project, each local community, the whole teams of experts participated. Those teams included medical staff, accountants, managers, etc. Such teams amounted up to 27 people, 29 people from each local community. You can imagine the scope of work which was done with each local community, and my working plan in a moment will show the outcomes which we are going to demonstrate on September 29th. The Working plan of our project started in the year 2021, where we explained the objective of the project in all local communities in Ukraine, in each regional hub. And we started with regional seminars opened for all the local communities, explaining the principles of local healthcare delivery. The topics remain relevant even now. Then we selected the participant communities, including the neighboring communities. We determined 5 participant communities, and with them we continued our analytical stage project, practical seminars, and analytical work. Here you see the colorful blocks of seminars and sessions which were held together with each, either with each local community or separately with several of them. The first block is analysis of expenses on each healthcare institutions. The latest event in this subdivision was on February 26, 2 days later after large-scale invention. Then the interval of 2 months started, and in May we resumed the project implementation. And we carried out additional collection of data about the influx of IDPs, about their place in the healthcare service delivery. Actually, this all were additional work to be done to the project tours. Then we analyzed the management of medical information. This block was about access to the medical information system, where we uploaded all collected data. That allowed the owners of healthcare institutions, experts, and managers to understand the situation with the primary and secondary service delivery. Thus, we assess the need in healthcare services and to shape the model of healthcare service delivery. This allowed us to offer a model for service delivery at the level of healthcare institutions, at the level of the system. Having shaped this model, we launched block number 3, managerial decisions based on the data, and we assessed financial risks. The next step was to assess budget losses and possible local budget programs to support healthcare service. Then we had to assess needs and the investment needs assessment. For example, how much was needed for reconstruction and development of the new structural subdivisions in line with the new model. What equipment and how much equipment had to be procured. We analyzed the need for partnership contracts between different local communities, neighboring local communities, which have to receive services from the neighboring communities, etc. And each of those stages gained some results, displayed some mistakes, and the outputs of our project comprise all that findings, all that will be presented at the final press conference of our project. We offered the control over complete data about losses carried out by hospitals, financial risks. We offered losses and possible solutions to raise income of the hospitals. For example, we offered assessment, investment assessment, investment needs assessment program for small local communities. We analyzed the need for creation of emergency services. All the findings were discussed with local communities, and recommendations were developed, and even templates for model contract between communities. Thus, we stimulated signing of memoranda between local communities about cooperation in the healthcare area. Thus, we come to the final events in our project. Currently, we finalize the project report for local communities and stakeholders. On September 19, we had final consultations with the ministry, with the National Healthcare Agency, where we presented our findings and our outputs, which we offer for further implementation to scale up the project in the next year. Today's press conference devoted to the project final, and on September 28, we will have final conference with involvement of experts and local communities who were project participants. The registration is open now, and you may follow the link under this broadcast and register for participation. In some invitations, we posted links to the indicators, indicator panels of the healthcare institutions with whom we cooperated in the project. Having checked this indicator panels, you will be able to understand the scale of the work which was carried out with the management. On our website, you may find links to the dashboards about the lists of primary healthcare services, their indicators, and find a lot of interesting information. I encourage you to visit that website. On the one hand, of course, this may raise many new questions. At the same time, you will find a lot of answers. And eventually, if you decide to provide your information, you will become a part of this huge open data system where the non-specified data will be collected. So the local, the community clinics, this should be the further focus. 40% of small and medium-sized hospitals in local communities currently are in a huge zone of risks. They are not separate institutions. They are part of system which has to provide services to the entire population. Then their needs should be seen as a part of the needs of the healthcare institutions in the region. This is a primary service, ambulatory service, and the hospital service. If you look at the neighboring countries, we understand that pre-hospital services amount to 80% of all services. Hospital services amount to 1.8% and 9% for other sorts of services. The similar picture are in other neighboring countries. From this point of view, the priorities for critical capacity infrastructure development has to be built because the primary services is critically important and requires a lot of services. Other services, which amount to 90%, they do not require big financing, but nevertheless, this should be quality services and prevent people from getting into hospital. And the primary service, primary healthcare services should cover 80% of the needs of local patients. Nevertheless, the situation with the grave situation with the local small hospitals is similar to many countries. In the United States, they also have a big project closing small hospitals in rural communities. Thus, they have closed and this brings local people to the problem how to get proper health care. And today, WHO organization made emphasis on primary service, its accessibility, increasing its accessibility, and small hospitals have to rethink their models and step back from multi-faceted, multi-profile departments. They should be turned into the different model, multidisciplinary, multi-professional teams, and negative consequences of closing hospitals increase risks for the patients. This require well-weighted decision from local communities. During all our events, all our seminars, we point out to these issues. The small hospitals in rural areas, they are primarily important for residents in big cities too. That is, we have to find good solution for the small hospitals and rethink the model, the new role for those clinics. And turn them into municipal enterprises. This is the model which is not, which has not been existent in the past. this won't be community hospitals in full sense. They won't have many beds. They will offer slightly different approach, and they should be positioned separately as community clinics. This was the position of our experts, but the role, the format of those institutions should be tailored individually to for each community, and they should be oriented at outpatient service delivery. The communal hospitals and introduction of such hospitals may result in a system shock, and we have to keep this in mind to prevent it on time. We have to decide on the conditions how the service should be delivered in this interim period. Especially the emergency healthcare service delivery, and Dubevska rural community with a small clinic which is located in mountains. The clinic is small and 40-kilometer away cluster clinic is too far, especially in the mountain conditions. Another neighboring hospital is in 60 kilometers away, and that would require up to 90 minutes to get there. For such local communities, we understand that the high risk of injuries exist in the neighboring wood cutting enterprises and wood processing enterprises. There are a lot of camp making tourists who go to local forests, to mountains, and the risk of injuries is rather high. The local community amounts to 27,000 people, which is less than 40,000 or 50,000. It is not numerous. At the same time, the capability index is rather low, and this indicates that the local community would not be able to renovate the clinic. At the same time, the local community and the neighboring community have local ambulance centers. We have in total, they are managed by Chachevska Territorial Community, and Dubevska Territorial Community partially compensate the utility services of the CPMD, and this suggests that we have to rethink the number of those ambulance centers and low number of population capacity of the healthcare centers. We have to rethink about community clinic and unite primary and secondary healthcare services, and to provide better management and better capacity. Dubevska community is more interested and understands better the needs of population and will ensure delivery of healthcare services better. Saying that, we do not mean highly specialized healthcare services. We speak about mix of healthcare services. Also, we will demonstrate the financial gaps or gaps in funding. In the model, we calculated them based on the main packages of the medical guarantees forms. This approach requires integration of business processes in healthcare institutions. It's not just about changing the name or plaque. It requires rethinking of the patient routes, patient flows, the transportation, digitalization, informatization, proper use of equipment, one-day surgery equipment, etc. This is a comprehensive approach to renovation. I won't mention now all the recommendations. You will see them at our final conference. But we have to keep in mind that healthcare institutions in small communities can difficulties with adaptation of the changes which we discussed. This requires for us to find proper solution, that is how to allow people pay less, get better services, and to introduce medical innovative services. In the outputs of our project, in findings of our project, we suggested several models. On this slide, you see one of the clinics, one of the community clinics. We are positioning them as not as hospitals. We should not call them hospitals because this will result in perception of these centers as hospitals. We suggest to call them community clinics. Several services, internal medicines, rehabilitation, nurse services, one-day surgery, etc. Also, there should be diagnostics and ambulance assistance. Actually, these findings are offered for discussion. We have calculations which substantiate what we offer. I would like to remind you that the changes which we suggest to introduce will involve the renovation and rebuilding of Ukraine. There are funding allocated for that purpose, and today the WHO insisted that renovation of Ukrainian healthcare clinics should be based on the new model, new role, not just rebuild the old premises. Selection of the projects for the renovation had to finish on September 2. I would like to point out that the careful selection of the project should be extended. For example, Vysokopilya recently was deoccupied, and as far as I know, they had a hospital, 40 beds, several thousand of square meters. It is ruined by 50%. The renovation need is around 50 billion euros. There is no water supply, electricity supply, etc. If you look at the future modeling and look at the neighboring localities and neighboring communities, there is 12,000 population and neighboring communities. According to our primary modeling, we understand that 90 minutes, which will be required to reach neighboring cluster hospitals, this requirement is not satisfied, and Vysokopilya has to become a special clinic without beds, outpatient clinic. What does it mean? It means that this healthcare institution will require very special attention, and just rebuilding and wasting such huge amount of money without taking into account its future role is only a waste of money. According to the prospective plan of Kherson region development in 2019, member of our expert group Ninel Kadyrova developed business plan for Kherson region, and that contained suggestions of Vysokopilya clinic, and even at that time that recommendations were provided, and now we clearly see that that previous recommendations coincide with what we have today. But all those recommendations should not be taken separately from Veliko-Alexandrivska Hospital development, which will take part of functions which will be deprived from the Vysokopilya cluster community clinic. It's not reconstruction, it's renovation of the entire network, and the renovation of the network should be done before the reconstruction would start. I'm wrapping up. The management of financial resources could be done at the strategic, at the tactical level. The strategic level is at the level of the National Healthcare Service of Ukraine. It is regulated at the level of the healthcare guarantees for the year 2023. One-day surgery, which has to be offered at the local level, is prevented from happening due to the limited equipment and technical means on site. The clinics, community clinics, would not be able to offer these services, and program of medical guarantees has to be corrected to include these services. The intensive care units are not needed for one-day surgery, and because of the new improved technology of anesthetics, etc. we have to reshape the model for service delivery. For example, whether surgery in hospitals will be limited in future or not. The change of the program of medical guarantees should be taken into account and reviewed. As far as I know, the package is now under review. Resources for innovation should be rethinked and allocated. The ministry has to understand the sources of funding and decide about proper management of staff. We have to rethink statistics and in order to plan properly. The information management system for managerial decisions should be improved. We provided a lot of recommendations on this issue. As of now, we lack many data to make well-informed managerial decisions, both at the local and central level. Recently, we found that 23 billion hryvnia residues at the accounts of the healthcare institutions could be assessed properly and reallocated for the program of medical guarantees. The program of medical guarantees should be rethinked and corrected with the incorporation of what we suggested and with the suggested renovation of the entire system. Of course, we have to decrease expenses, we have to decrease energy consumption, etc. I already mentioned the signing of the memorandum with the Association of Local Communities, and thus we start movement towards our next project, which will be a multi-component project. This will be called Renovation Community Clinic, that is renovation of healthcare services at the level of communities. We will analyze that aspects, and we hope for the support of our colleagues. With this, I will finish my presentation, and I would like to give the floor to Vidmantas Eigelis. If you are here, we always try to involve our international partners and experts because they have broad experience in similar challenges that we have now. Vidmantas, if you are here, the floor is yours. Dear colleagues, I'm happy to meet with you once again. Of course, I'm always happy that you follow the same route of transformation. We started our reform back in 1997. You had started your reform just in 2017, and you are already ahead of us in some aspects of this reform. But what we would like to wish you, please do not repeat our mistakes, and keep in mind the lessons that were learned from our mistakes. Kateryna mentioned that we have to devote more attention to the primary services and psychosocial assistance, and in this aspect, we may provide good experience because in 1997, the reform in that aspect was quite successful. And if you wish to think about psychological assistance to population, about psychiatric assistance to population after the war, we may demonstrate good experience that primary psychiatric assistance is separate from family medicine. Family doctors, they exist separately from the psychiatric support, and having separated two types of services allow you to provide better service to population. I would like also to warn you that psychosocial rehabilitation at primarily level should be well calculated in terms of money, in terms of finance, because psychosocial rehabilitation at the primary level is extremely or comparatively expensive service, and to provide it at a better level, you have to cover bigger amounts of population. That is psychosocial rehabilitation should exist over 10,000 of population. Otherwise, there won't be any quality service. There might be only attempts which may become very expensive. I am very much supportive to Valentyna Poltavets, who mentioned that the role of rural hospitals should be clearly determined. Please capitalize on our lesson. When we implemented decentralization, we were very happy that all local communities have got their local hospitals, etc. But the role of regional or district hospital was not clearly determined, and it was rather vague. Having analyzed your decisions, your documents, and your reform, you are following the same steps that we made. You had described over cluster level university hospitals, the cluster level, the regional hospitals, but the under cluster level, the district hospitals or clinics are not properly described and determined in their role. Our approach to the upper level resulted in decentralization of healthcare services with a high centralization of funding at the central level. University and cluster clinics and hospitals in the first years of our medical reform received much better funding in the at the beginning, while the district clinics and hospitals started to face huge financial problems. At the beginning, we believed that that was just temporary obstacle, but eventually, and I showed that slides at the previous seminar, but that resulted in huge financial losses to district clinics and hospitals, and that kept growing within a range of 3 years. And that brought us to the idea that districts, hospitals had to be united with the primary healthcare sector. That is, you have to determine which services would be provided by district hospitals. You should not say that to district hospitals you will need to struggle and fight for the funding packages. That won't be possible. At the moment when we suggested that some districts had procured very expensive equipment. But that equipment, which was centralized in more or less big cities, it is useless to people in remote rural communities. You may suggest the less a district it is, the more aged population reside in it. That suggests only that you have to provide gerontological services. On the other hand, when you start to do only one type of service, like gerontology, then you cannot find medical specialists who would work on that. You think about equipment, but you forget about people who will work with that equipment. Today in Lithuania, and you in 2-3 years will face the same issue. We faced huge migration, outflow of doctors and nurses, and now we lack many of doctors and nurses. The situation that Ukraine faces now with war and outflow of displaced people and among displaced people, there are doctors and nurses who are abroad. Only in Lithuania, which is comparative, in our small hospital, we have 7 Ukrainian nurses who work here and 2 doctors who work in it. Having worked here in Lithuania for some time, for a while, and if we will be able to provide them with Lithuanian licenses, you will compete with us, and Ukrainian doctors will decide whether to stay here or to come back to Ukraine. Frankly speaking, today you cannot compare Ukrainian wages with Lithuanian wages paid to doctors. While Ukrainian doctors in Germany can easily get licenses, and the wages in Germany for Ukrainians are much higher. So you have to decide how you will provide staffing of those hospitals. And today, the wages amount to 65 or 85% in healthcare services. Besides energy issues, the most expensive part of our healthcare services are doctors and nurses, that is, people, wages. And perhaps you have noticed that not always medical workers can manage their resources. We may decide that we redirect patients to different hospitals, that hospital, this hospital, that clinic, that clinic. But how patients would get to that hospital? Looking at the map, it seems that 15 kilometers is not a big distance, but the bus route takes up to 2 hours to get from a village to the new hospital to which you redirected the patients. So you have to look not just on the map, but to decide about transportation, public transport, etc. There was a good comment, and keep it in mind. Do not make decisions which are written on stone. It may seem that towns look similar, but the density of population may differ. From my experience of work in a small hospital in a city where the density of population was 900 people per 1 square kilometer, and in neighboring community there was a hospital in the same community with the same population, but the density of 20 patients per 1 square kilometer. This suggests that logistics is quite different in these two neighboring hospitals, and the patient load is quite different. If you think about logistics which is proper for big cities and apply them for small rural community, that would be a catastrophe, a disaster. You should have 3 models: big megapolis. This is one level of problem. Big cities, 1 million cities, they are different. And rural areas, this is something third. I worked with the Zaporizhia region, and we found out that almost for each hospital, you should have a flexible model. In order to introduce any reform, you should see something. When in Zaporizhia we described what should be done, we met the astonished glances, but then we brought people from Zaporizhia region to Lithuania and showed them when leaving Lithuania after that visit, they started to make projections for their local hospitals. This suggests that calculations on paper and building up models on paper is one thing, but seeing that in reality is quite another thing, and we invite you to come and see. when you say now that primary and secondary service should be separated in small districts, but after 10 years we are bringing them together in small districts, I would like to encourage the audience and say that I am always happy to study the international experience, and I am pleased to invite you to the conference. We will have a session of questions and answers with our experts. Dear colleagues, thank you for participation in this event. We are finalizing our conference devoted to the wrap-up of the project developing effective networks of healthcare institutions at the community level in decentralization and martial law. We encourage you to visit our conference on September 28th and to register for it in the internet. We all believe in the victory. We will overcome. Thank you for participating. Ukrainian Crisis Media Center is also grateful to you. Thank you.